and good morning to my friends and senior people here. The topic given to me is monitoring and follow-up. I am not going to talk anything from the association recommendation, anything else. I'm going to talk from my own experience. So whenever I say monitoring and follow-up, something called glycemic monitoring and non-glycemic monitoring. Glycemic, we all know that HbA1c and fasting plasma glucose and postprandial CBG and CGM, all these things we talk about. A non-glycemic comorbid complications, lifestyles and others has to be looked into it. There is something changed, new terminology has been changed. Capillary blood glucose has been replaced by self-monitoring of blood plasma glucose, and flash glucose monitoring, usually what we call it as, has been changed as intermittent scanned continuous glucose monitoring. And continuous glucose monitoring has been changed as real-time continuous glucose monitoring. Because the terminology has been changed, we are going to use this terminology. As we say, the new technology in monitoring, we talk about glycemic management indicator. That is something called, whenever you have a continuous glucose monitoring, there's a calculated HbA1c comes in the top of the any slide. You see that that is called as glucose management indicator, and glycemic variability, it should be less than 36. Time in range should be more than 70, and time below range, if it is less than 54, it is very severe hypoglycemia, or 54 to 70, there is also our target is there. Time above range also a target, more than 180 to 250 or more than 250, there is also a target. So we all now talked about so much about glycosylated hemoglobin. I want to insist that even though the glycosylated hemoglobin, we said it is average of 3 months glycemic control, the 50% of weightage given to the last 1 month. That is the most important point we should keep in mind. So if a patient is very well controlled HbA1c, blood sugar is stable, everything is stable, we can do HbA1c once in 6 months, not needed to repeat once in 3 months. And factors which can affect HbA1c, we should keep in mind whenever we are interpreting HbA1c. All the hemoglobinopathies, whenever the blood is going to loss or blood is going to stay, it alters the hemoglobin. Fetal hemoglobin, hemoglobinopathies, methemoglobin, and some drugs like vitamin C, E, and chronic renal failure, splenomegaly. Whenever the red blood cell life going to be extended, HbA1c will be altered. Or whenever the HbA1c life has been shortened, HbA1c will be altered. That is the one point you should keep in mind. So before interpreting HbA1c, look for hemoglobin. If it is fine, then we can go with the hemoglobin. And capillary blood glucose monitoring, we say home glucose monitoring. Don't ask people just to do just regular monitoring. Always monitor with a meaning. Whenever you have a sugar, you should keep in mind what is my sugar level should be, and whether I'm looking for hypoglycemia or hyperglycemia. So we have to teach our patients then how to perform HbA1c, when to perform glucose monitoring, how to record it. Many people who do sugar regularly, but they won't record. That is common scenario come across in our practice. And whenever the hypo or a hyper happens, how to react. That is also, otherwise many people get panic. Sir, my sugar 300, 350, how to come, where to come? They come rushing. Without taking tablets, the sugar level go up. When they had on papayasam, sugar level go up. Immediately rush to the doctor. Only they give the fees alone, nothing else. So the continuous glucose monitoring, always individualize. So whenever the patient is on insulin, basal bolus therapy, 3 times or 4 times therapy, or patient on pregnancy, we are going for basal bolus, we need 4 times or once in 2 weeks or once in a week. If patient is very well stable, OHA with a milder dose, the drugs will not cause hypoglycemia like gliptins, metformin alone, we ask them to do blood sugar once in 2 weeks or once in a month. So it is individualized. Nothing fixed that every week you have to do a blood glucose monitoring. While talking about continuous glucose monitoring, we discussed about real time or intermittent testing glucose, continuous glucose monitoring, or real time continuous glucose monitoring. Not much difference, but the real time is obviously scores over from the intermittent continuous glucose monitoring, where the real time used for reducing the HbA1c to maximize the TIR. But the intermittent scanning is, even though it increases TIR, the major role here is to reduce a hypo risk. But always, whenever we are discussing or whenever we are looking for continuous glucose monitoring, I should concentrate in the bottom line here. Does patient, some devices may biased with overcall hypoglycemia. So just continuous glucose monitoring shows hypoglycemia. Don't overtreat or don't undertreat. Look for symptoms. Many times hypoglycemia will be overestimated in continuous glucose monitoring devices, particularly intermittent continuous glucose monitoring devices. This is about continuous glucose monitoring reports we will get. You have seen many cases. This is about international recommendation. In type 2 we are concerned about. In type 2 the target in range should be more than 70, or hypo range should be less than 50, hyper range should be less than 25. That is what our aim. Nowadays, after the NMC has been cleared, remote monitoring has been approved for diabetes care. So many people are using so many apps. We are having online monitoring systems. So many apps are available. Almost 1,598 startup has been started for the glucose monitoring, remote monitoring. So whatever way you convenient, but we make sure that the patient is safe. The same time will not develop hypo and hyperglycemia. That is the only thing we need to. This is about glycemic monitoring part. I am coming for non-glycemic monitoring part. Non-glycemic monitoring part, we know that blood pressure, dyslipidemia, and always the main aim of diabetes management is reducing the cardiovascular risk, and nowadays we talk about renal risk also. So whenever any patients, newly detected patient or already diabetic patients, whenever comes to us, we should talk about diet. Without asking diet, don't escalate or de-escalate the dose. We should every time reinforce about what are the bad food, what are the bad diet we should not follow. So it is a simple chart. I want to keep in mind that whenever, if you see our Panneerselvam sir booklet, you know that what patient had, what patient should not had, everything has been written in clear. So sir will ask every time about diet. I know that. So we should also follow that. Every time, what is the patient diet? Just looking for blood sugar alone, not sufficient enough. And lifestyle also, whether the patient have regular walking, regular exercise. By skipping a walk for a week, definitely increase the sugar. Skipping a walk for a month, patient will elevate the sugar. So before escalating the dose, ask for the lifestyle. What about the sleep pattern? What about the lifestyle? What about the diet pattern? What time we have breakfast? All these things has to be considered. In summer, we all know that dehydration also elevates the sugar. So we have to look for hydration also. And non-glycemic monitoring, other is medications. Many a time our patients do blood sugar without taking the tablet. So always we escalate the dose without asking that the patient will develop hypoglycemia. We induce brittleness rather than patient will induce that. So before escalating the dose or before de-escalating the dose, check for whether the medication is proper, there is no poor compliance with the drugs, the postprandial blood sugar has been taken in time with the drugs. That is the one question whenever you are escalating the dose, you have to ask for. And another one parameter, non-glycemic parameter, which alters the sugar is behavior changes. Obviously, we know that depression, anxiety, stress, all these things also alters the blood sugar levels. So we should keep in that, while talking one or two words, you can able to understand how the patient reacts. So whether the patient is in depression, if so much complaints comes in, particularly lady 40 plus, 50 plus, always complaining, look for depression. And non-glycemic monitoring, we all look for comorbids. We all know that. We look for blood pressure, diabetes, lung diseases, CLD or chronic COPDs, and deficiencies, anemia, vitamin D, vitamin B12, and we have to look for renal markers, and always obesity also be included in. Whenever we are calling, whenever patients comes to us in a clinical examination, physical examination need to be monitored about height, weight, BMI. That is the first look at. And blood pressure has to be checked each and every visit. And fundoscopy, if possible, you can do it. Otherwise, at least once a year. And thyroid, we have to look for, at least just inspect. If a suspect, we go for palpation. And skin examination, particularly acanthosis. Many a times, we think of only pure type 2. It could be a double diabetes. Type 2 with some acanthosis will be there. The adolescent age. As an Indian, we are prone for insulin resistance. We come across only type 1, type 1, type 1. But once you become adolescent, once you become teen or crossing 25 plus, look for acanthosis. Many people will have double diabetes. And comprehensive food examination is a mandatory in each and every clinical visit. look for, inspect any food changes, cracks, dryness, or any fissures, anything happens, and screen for PAD. That may be actual screening with the machines can be done once in a year, but just look for PAD, and temperature, all these things can be done once in a year. And screen for depression, anxiety. By discussing with the patient, you can be able to understand. If you have doubt, go for the scores. And cognitive performance, functional performance, all these things can be assessed each and every clinic. Laboratory test, we need to monitor HbA1c. Already we know that lipid profile, so many recommendations have so many data. So lipid profile at time of diagnosis, once the blood sugar has been controlled, look for lipid profile. So uncontrolled blood sugar definitely have hypertriglyceridemia. We tend to over-treat them. So first achieve a glycemic control, then look for lipid profile. If lipid profile is abnormal, you go with the medicines. Or if a patient is more than 40, high risk of CVD, straight away go with the statin irrespective of the lipid profile. No need to monitor lipid profile. If at all the patient insists, go once in a year. And spot urinary albumin creatinine ratio, that is also at time of diagnosis. At time of diagnosis means once a glycemic control has been achieved. So annually, and thyroid function test in type 1 diabetes, in type 2 at least once in a year. Vitamin D, B12 if a patient is on metformin once in a year. Complete blood count once in a year, and potassium and other markers if a patient is on AC inhibitors, ARBs or diuretics. Calcium, vitamin D, phosphorus at least once in a year. So we have to look for complications also. We know that how to do complication screening. I don't want to spend extra time how to spend nephropathy assessment, retinopathy assessment, peripheral neuropathy, ischemic heart disease and peripheral vascular disease. I wish to insist that these things also be monitored once in a year. And vaccination. This is nowadays picking up very well after the COVID. Many patients do accept vaccination. Maybe after Covishield from AstraZeneca, many people will assist for vaccination also. So we have to look for the patient had a regular timed vaccination. So at each and every clinical visit, look for blood pressure, food examination, weight and BMI, symptoms of ALIS and hypos, look for ketone body assessment or any infective foci, and smoking, alcohol cessation has to be insisted on each and every clinical visit, and drug adverse affection. Many patients, we think that SGL2 melanocytosis will be there, or sometimes patient may have some other adverse reaction, pedal edema with amlodipine, cough with the ARBs. These are quite common. So we have to look for adverse effect. And whenever patient on insulin, look for injection site. How the patient rotate the site. Is there any hypertrophy or hypotrophy occurs? And drug and food mismatch. That is what most commonly occurs. Before de-escalating or escalating the dose, look for food. Whether the patient had a right tablet, right time, what is the food patient had, what is the test they have done, what about the sleep and lifestyle pattern, all these things has to be monitored. To summarize, diabetes, evaluate diabetes complication always, potential comorbid condition has to be evaluated, overall health status has to be always monitored in any diabetic patients. Review patients' previous treatment and risk factor management in people with established diabetes. Always de-escalate or escalate the dose according to the patient lifestyle. A follow-up visit should be most comprehensive, initial comprehensive medical evaluation. First visit itself, we should have a comprehensive evaluation. The follow-up visit, whether we are doing right or right, we have to follow it up. And ongoing management should be guided by assessment of overall health status, diabetic complications, cardiovascular risk, hypoglycemia risk, shared decision making with the patient. Just because you have started with one drug, it doesn't need that patient need to be continuing always that. So you have to change the drug, or you can accept that the patient, this is a drug's adverse effect. We have to monitor that, we have to change that. And develop a plan for continuing diabetes care with diabetic education for lifelong. So we discuss with the patient, as a patient is a main tool, all the associations do recommend that. So we have to always go with the patients. Whenever patient comes to our clinic, always give some tips about diabetes. And what is diabetes? Keep insisting on insulinization. Patient after 10 years, patient may need insulinization. Many times patient will not accept unless we discuss about insulin at least 3 or 4 visits previous itself. Thank you for your patience.